Welcome to Encouragement for Living Life with Lockwood and Lockwood. The guys are here to encourage you in your attempt to live more confidently and successfully in our world. They are highly trained and experienced mental health professionals, but they are not your mental health professional. They are sharing encouragement through information and discussion. People are complex. Just because an idea helps one person doesn't mean it will help someone else. You need to consult with your own professional who will hopefully know what is best for you and your situation. Now, it's time for Lockwood and Lockwood.
For those people that actually pay attention to things like this, you'll notice that my hair is radically different than it was in prior podcasts. And that's because I'm preparing for total knee replacement surgery next week, which will be hopefully be over by the time you see this podcast. But that's why there's a radical difference in my appearance, if you're wondering about that, and only God knows why I'm sleeping so good.
Good.
With that coming up. Anyway, today right? Today we want to talk about, again, what do I do? Don't use a squirt gun on a house fire. What do I do? Types of treatment. And this is really part one of this. And we want to go over some basic types of treatment today, but all throughout our podcast over the next number of months, we're going to go over different types of treatments. And today we're going to go over psychotherapy or counseling, intensive outpatient programs, and medication. Some big areas, and we're certainly not going to be exhaustive in our approach and explaining these things to you and what they do and don't do and all those kind of things, but we're going to give it a shot. And so we're going to start with psychotherapy and counseling. And I have a different thought than when we talked about this earlier. I really do believe, I think I was discounting myself. I really do believe there's a difference between psychotherapy and counseling. I used to joke that psychotherapy is 200 plus an hour, counseling is around 100 an hour. And I think in my joke, I'm telling some truth about what I believe. And the truth is, I believe that counseling is typically what people more think about cognitive behavioral approaches that are very widespread, used greatly by the vast majority of people in the world today. Some can be more intensive than others, but by design, they're not meant to do what a more intensive approach like a psychoanalytic approach would be. And I'm sure you're going to give me some feedback on this, but let me finish. So I think it takes a greater degree of skill and training, education to do something as intensive as what I do. One of my patients yesterday said, "God, you have a lot of power." And I listened to that. And of course, she has fear about the things that she's dealing with because she felt so co-opted and used by the maternal relationship particularly early in life. And to go back and do a regressive kind of therapy where you're going to have more and more power as a psychotherapist. And most cognitive behavioral approaches do not try and do this kind of stuff. But if you really want rewiring done in your brain, the more intensive work you do, the more likely rewiring is to occur, particularly people that are hurt tremendously, severely damaged by their background. That's a caveat that's important. So I do believe there is a difference that's how I've always divided them in my mind. I don't know if that's fair or not fair, but that is how I've divided them. I heard about a psychologist, who's making $100,000 because it was a Ramsey show, they're talking about how much their income is as part of their discussion. And I go, that's probably about 20 sessions a week at $100 a pop. And that's a PhD. And that's a different level of, I think, intervention with people generally. And I'm not saying there's some people who do cognitive behavioral that don't do very intensive work. There are. And there are analytic people, psychoanalytic people that do less intensive work for specific reasons based on the patient's needs, too. But generally, you really got to know a lot, have a lot of experience, and have great integrity to do the kind of work that I do. We're going to talk about stuff like that today. Counseling and psychotherapy. So to start with, that's kind of how I divide them. So, all right, son, give me some feedback here and give folks some information.
Yeah, I think it's really weird because people with different types of degrees do different types of things. So something you're saying, which is true, is there are people with doctorate degrees, PhDs, MDs, There are people with master's degrees, people with no degrees who do what you would call counseling, right? And so one way to think about counseling versus therapy, and now this is muddy, but this is just first thought,
Right.
so one simple way to divide this, not that it's the only way, is counselors are focused more on guidance. So you're taking an active role to guide where things are going. And so it's, if you want to think of it like more 50-50, right? Where it's like 50% on the patient or client in counseling settings and 50% on the person who's doing the counseling. And so both are equal parties, equally responsible for whatever goal creation and change process is happening towards very concrete ends. So like my brief
Right.
recollection of the history, basically speaking, is most people that did counseling earlier on in the 1900s, they came out of like the guidance counseling world. So it was like vocational counseling, career counseling, working with people who were recently fired, working with people who were displaced, working with people who were new immigrants, working. So it's a very practical, like, let me help you get to that next practical, achievable, concrete, tangible goal.
Right.
So it was less about mental suffering originally in the early 1900s and more about achieving practical concrete goals like getting a job or managing your finances or whatever it was. And that evolved over time because, as always happens, everything kind of mixes in. And so, there are all the
When I gotta get my coffee, I forgot my coffee.
yeah, that's fine. And in everything that you're describing with regard to the challenges of, let's call it, um the people who call themselves counselors who do therapy, is there's all these new organizations, for instance. So there's like pastoral counseling, and pastoral counseling is one of these types of interventions that sits on this really weird border between being old school counseling, spiritual guidance, and psychotherapy. It kind of lives in that weird gray zone.
It does.
And
Yeah.
and so like the field evolved a lot in the last 100 years plus. And so counseling is now mostly synonymously used with therapy in a lot of circles because people that call themselves counselors. So they're an alcohol and drug counselor. And really what you're trying to do is like therapy light with people with substance use disorders, specifically focused on this one problem.
Yes.
So in essence, it's really more about the professional is what I think. So there are people I know with just counseling credentials, so KDAX and all these things, who actually do what I would call psychotherapy. They're focused on, emotional issues and patterns of thinking and and all these things that therapists actually address, usually. Whereas there are people with PhDs and MDs and all these things who just do counseling. They're just trying to guide you practically, concretely through steps to get to some next thing, right? And so
Right.
I don't think that the degree or credential difference is really the important focus. I think the important focus is what is the actual mutually negotiated goal, right? So in psychotherapy, you sit down with a clinician, usually, who has some understanding of the types of things that you're bringing to the room. And then you collaboratively go, okay, what's the case formulation? What do you think is happening? What are the mechanisms that are maintaining the problem, emotions, thoughts, behaviors, to be super concrete about it for everyone? And then what do we want to try to do together? Right. Which is different than in counseling, where it's like, I can't manage my marriage. So I'm going to learn how to be more assertive and I'm going to practice this skill. Right. Or I can't stay sober. So I'm going to practice coping skills. Or I can't get a job. So I'm going to learn how to improve my assertiveness skills so I sound more professional. So counseling is very skills, practical, tangible, concrete focused usually. Not that insight plays no role or that healing doesn't happen. It's just that therapy is more focused on insight, healing, not only acute behavior change, but long-term patterns of thinking and feeling and behavior change.
Which I think relates to this whole newer area of rewiring the brain. I think there's a real correlation, two correlations in the ability to rewire the brain. One is how damaged a person is. And the second is how intensive is the approach to that particular issue. Some people that aren't damaged greatly, hurt greatly, can do some what I would call more cognitive behavioral work and change greatly, tremendously. But people that are deeply hurt, that need much more intensive approach, which is most of the population that I've treated, in my career, particularly the last 30 years. And so I think it's one of the things we want to get across to people is you don't want to use this work on a house fire. You don't what you describe as counseling, use with someone who has some deep, deep history of damage that they don't even know what's wrong. Well, I see a lot of people that can't even tell you what's wrong when they come in. That's how damaged they are.
I'd like to plant just a flag real quick because I think this is important for everyone. So you used a couple of adjectives that people might not understand are more meaningful than they actually are. So you've used the word intense a number of times, and especially throughout other podcasts together, you've said the word intense, right? Intense therapy, etc. And you've used the word deep. And so those two words, I think you're using fairly interchangeably. And I don't want people to get just see these as throwaway words. So I believe
right.
I believe you mean something very specific. So this is going to be taking a stab at it. So when you're talking about people who are deeply injured or you're doing intense psychotherapy, you're trying to talk about the same thing, which is there are people who have either, types of psychological issues where they were neglected or hurt or even traumatized or whatever, kind of use those words.
Right.
Early on in life, typically, but also not just early on, but pervasive, which means it happens a lot over time.
Yeah.
And so the people that experience repeated neglect, and it doesn't have to be like you couldn't eat today. It can be like no one said hello to you today, even though that doesn't seem like a huge deal for some people because of how they're built or personality, whatever. That could be traumatic for them, even though it just seems like you're being dismissed and who cares. And so the early, pervasive, consistent pattern neglect, pattern feeling overwhelmed or helpless is what you're referring to. And some of that happens before you have language, and some of that happens after you have language. And so when you're talking about intense and deep, you're talking about these extensive experiences that people can have that don't seem like a big deal to the outside observer, right? So if you're watching a movie about some kid who's being pervasively neglected from the age of 3 to the age of 8, for instance, or
abused,
whatever, right? So either's fine. Neglect and abuse, both are fine words. So whatever it is, it's like from 3 to 8, no one said hi, as just the easy example to pick on. Depending upon how you're built, depending on your personality and stuff, that 3 to 8 period, it's only 5 years. So 5 years is not a long period of your life. But because it's an early development, because it's before you have a lot of bodily autonomy, because you're going through all these psychological changes to develop autonomy and become a real person, that can be very hard for people or even traumatic for people. And so when you're talking about deep, you're not talking about like being in a horrible sexual assault situation necessarily, even though that's very tragic and hard for people. That could be deep or it might not be. But for a lot of people, these things that are like, let's call them characterological, as your character is developing in early life, that can feel deep to people, even if it doesn't seem like a big deal to the outside world. And that, I think, is what you're talking.
Oh, absolutely. Thank you for putting a lot of good words on that for people so they understand that. So when I say deep or intensive, I can give people one example of this with trauma. Trauma typically are incidents like assault, sexual assault, physical assault, um, some severe incidents of being screamed at, threatened, that create in the brain something that's really sticks deeply into the brain and amygdala that feels very traumatic, where they feel overwhelmed, helpless, And there's a lot of consequences from those incidents, those few incidents or one or more incidents of trauma. I joke with the people I treat, some of which have had those incidents, but I deal with people who, we don't call it trauma in my business. We call it annihilation of the self. That people who, what you described is from an early, very, very early age, a lot of people I treat from zero, some in utero, in terms of how they were treated in utero even, that felt profoundly overwhelmed to the point where they felt like who they were was being annihilated. And this is long before words could be put on things, like you said, with some young children. And they don't even know how to put words on these kind of things. And one of the things we do in therapy is begin to try and go back and look and put some words on what they physiologically, emotionally experienced as young children. And these result in some very severe characterological issues, personality issues that can be really crippling. And I see people who are highly functional in some ways. They can earn a great living, some of them. Some of them, it cripples their ability to earn a living. But in certain areas, particularly relationally and emotionally, they're extremely crippled in terms of relationship and emotions, i.e. diagnosed like depression, anxiety, sometimes personality disorder diagnosis, and certainly trauma diagnosis. But it's much worse when there's a pervasive pattern of neglect or abuse that goes on for years from an early age,
Sure.
and incidences of trauma. And I'm not downplaying the seriousness of any trauma.
Yeah.
It hurts people. It can be crippling to people. We know that. We see it. We deal with it all the time. But I deal with those people that it's more pervasive, and I would not call it trauma. I call it the annihilation of the self from a very early age.
You deal with a very rare group of people, just so everyone's clear. Like if we look at it from like the population level. So
Yes.
a lot of people experience what I would call ordinary neglect or ordinary difficulty, ordinary stress in early development. So no one has a perfect childhood, just so we're all clear. No one has perfect parents. No one goes through development seamlessly. Every little kid has some medical thing or some injury. Every little kid has parents who are busy, especially nowadays. So like what we are talking about is not like ordinary mom didn't say goodnight, dad didn't say he loved me bullshit. We're talking about like pervasive is the word that both you and I used, and that's probably the best word. Like it happens all the time in so many different ways. It's not like someone had a bad day this week and they were a dick to you. It's they've been like this consistently across months and years even. And so like it's not like your parents have to be like perfect or something for you to end up okay, or your parents have to be um some kind of monsters for you to end up like this. It's more complicated than that. So I don't want people to walk away from this thinking, oh shoot, if I don't hug my kid or something, some tragedy is going to befall them and they're going to need super deep. Well, that's just not true.
In my field, we call it good enough parenting. It's far from perfect parenting, but good enough. And one of the keys of good enough parenting is when there is a mishap in a relationship. If a parent can go back and correct it, apologize, change. If they really need to change something, really change it. Sometimes you don't need to change anything. You just need to apologize for having hurt their feelings or miss something that's important to them. Those corrective experiences do a wonderful job of building good relationship and good internal structure inside of a child. And structure, by the way, I mean self-worth and security, the two main things that people like me look at in terms of people's ability to function in the world. If they have enough security, again, good enough, and enough self-worth, they can move around this world pretty freely and get their needs met and meet others' needs.
Yeah, it's rupture and repair to be more practical about it. So like,
Well, that's actually more technical.
but it's like
You're right. It's rupture and repair. Yeah.
yeah. I mean, like, and so what we're talking about is we're talking about the people that never experience repair, right? We're talking about the people, or the people who couldn't speak up for themselves in some cases, right? And so there's, again, it's super complicated. We can get in the weeds, but that's not the purpose of this.
No. But the point is, we're on the same page here. The point is, when you're listening to us, you're going, well, what do I need?
Yeah.
Well, the point here is very simple. The worse you were hurt, and you may not know how bad you were hurt either, so that category is a little tough to help you with. But if you know how badly you're hurt, you can kind of go, well, what do I need psychotherapy or counseling wise? Do I need a more of an intensive approach, someone like me that deals with these really extreme things? Or do I need someone that just can help sort out what's going on with me, help me do some personal growth to help reduce, say, anxiety, depression? I do a lot of people, my patients have a lot of depression, persistent depressive disorder, because these things happen so early in their childhood, it's affected their whole life. But it's a different kind of depression than someone else who's gone through a really tough time and their emotional resources have been drained, and they end up with a major depression or even some chronic persistent depressive disorder too. See, so you have to kind of know what's behind it. So if you happen to know your story enough, and sometimes people I treat, they don't even know their story. But if you
Yeah.
know your story enough, you can kind of get a gauge on, well, what do I need? How experienced the therapist, how extensive, what's their background? Do you need someone that's heavy psychoanalytic? I see people 2 and 3 times a week for years because of how much damage there is to wade through to even get to the real self and then try and repair it. Very difficult. The defense systems are amazing, amazing. Anyway, so it's a whole different kind of an animal. So we want you to get an understanding of, if you can, and you may not be able to, but if you can, do I need something bigger than a squirt gun? Yeah, I need something that's a little heavier or really, really heavy. And some people know you may know you need something really, really heavy, you know, but you may not know that. But I'd listen to them if they're talking like that with you.
Yeah.
So
I think there's a couple of different ways to talk about this, because some people really do need depth and they can't understand that they need some more intensive thing. They're not ready to be technical about it, like pre-contemplation, state of change, whatever. But
yeah,
but
right.
but also, some people might be very, very self-critical and hyper neurotic, but actually not be that damaged, you know? And so they might still have some issues to work through in therapy, but they're used to playing this family of origin game where it's like, me being sick is the only way to get attention, for instance, which can come from deeper things or it can be shallow. I've seen both in my career. I'm sure you have too,
Right. Sure.
you know? And so, like, I want everyone to be clear that it's not super simple or super obvious. Even really good therapists can miss some easy, obvious things that don't take years to deal with. And even really good therapists can miss some really deep things because they can't understand, right? So one of the hard
Right.
things about this work, just so everyone's clear, is insight is not a one directional thing where, like, the therapist helps you develop insight. Insight is a two directional thing. So however insightful your therapist is however insightful they can help you become, basically.
Well, I even say insight with my patients is a side effect of the work. It's not the
Yeah.
purpose of the work.
Yeah.
It's a side effect that they learn things about themselves or families with their situations that they might not have ever learned before, but it's
Yeah.
not the purpose.
Yeah,
And
no, I agree. That's usually like a narcissistic, I'm gonna help you develop this brilliant insight thing, which is just not, like, that's not what a good therapist does. A good therapist is trying to help you solve a practical problem that may be very complicated and even deep. And if insight happens, like you said, it's a byproduct. It's a side effect. It's a positive side effect of what you're doing in the relationship with the therapist.
correct.
Yeah.
Right.
Yeah, you and I agree about that. Yeah.
Yeah, for sure. So we're just trying to give you a sense of what is the degree of difficulty you have with living life, whatever. It doesn't matter what the diagnosis is. Well, it does matter also what the diagnosis is. You may not know what diagnosis you have. Well, people are much more informed because of the internet today, and often right. They do research about themselves, and they're often wrong too. I get a kick. A guy said he had a what kind of attachment he thought he had what's the one where it's all over the place?
Fearful or disorganized?
Disorganized attachment. And I said, no, you're highly organized, actually. And I went over and explained it to him. Very organized, anyway.
Yeah.
But, so you got to be careful too with what you read. Even bright people can, and he's very bright, can not understand what it is. This stuff can be very complicated. But we're just
You
trying
bet.
to give you a sense of, and this is particularly the thing I'll say a lot to people. If what you're doing, you've really been trying, working at it therapy-wise, counseling, whatever, and it's not, and you've given it really a good shot. I don't know how long you would think, son, but I would think at least a few months, unless it's so obvious in the beginning they don't get you at all and they don't know what the hell they're talking about. You know what I'm saying? But if you've given us a sufficient time for who you are, and you don't really get a sense that they get what's going on with you and have a direction with you, because many therapists, by the way, have no idea what to do with what you're talking about. They
Sure.
sadly don't. They can see a problem, but they don't know how do you get from point A to point B, with someone, and that's sad to me. And I'll probably trip off on that and maybe watch my language there too sometimes with that. But I'm really big on people getting what they need, as you know. So and for those listening, that's really important to me. And so many people
Sure.
not understood correctly. But stick with it. And if it isn't really working, try someone else. Look for a
Yeah.
higher level of training. And this is the joke from earlier. I have a master's degree. I do more intensive work than people with PhDs or MDs do. And most MDs now don't do a lot of psychotherapy, but in the old days, in the psychoanalytic field, the only people that really did it were MDs, doctors.
Yeah.
And now less and less doctors do that. They're doing more medication, hospitalization, acute care kind of stuff than they are doing actual psychotherapy. Some still do, and usually more cognitive behavioral now. So it's not really as much degree-based as it is training-based and what they focus their practice on.
Yeah.
So you got to be a good consumer. You got to know some questions they ask. People call me up and they'll ask questions. I answer their question on the phone, and give them some idea of what they're looking for, or I hear what they're looking for, and I let them know what I do. So they get some information, and sometimes I'll point them in a different direction. One of my patients has said, well, I want to do some premarital counseling with my girlfriend. And we talked it out. Do you need something more intensive? Do you need something lighter? How well does each of them know themselves? And both of them know themselves pretty well because they both have done some work on themselves. So we decided on something cognitive behavioral, and the girlfriend had a therapist, gave him a referral, and I said, try that and see how that goes. So you need some help sometimes, know where to go, but don't give up. That's the main thing for me. Try someone else and keep trying. I know too many people that are dead today in recovery, addiction recovery. Some went for help and didn't get the right help. And I'm not saying sometimes we can't accept the help either. So we have blocks on our side too. And others that never go for help that desperately need it and are dead because they didn't get the outside help. And they thought a 12-step program was going to do it all, and it doesn't for some people. It does for a lot of people, but not for all people. So that's my message with psychotherapy and counseling.
I think I can generally agree about don't give up. I think there's a subset of the population that actually just doesn't need therapy. I might call them the worried well, which is a phrase some people don't like. Just to be clear, I think there's a segment of the population that seeks out therapy or counseling because they badly don't want to be an adult and they badly don't want to be a real person. And they have all the skills and insight and knowledge they need to function and be okay and live a good life, but they just don't want to do it themselves. And fair enough, but go get other relationships. So that's one group of people, but I don't think that that's the largest group of people that seeks out therapy, to be honest. I think there's a minority of hobby therapists who take on those people, but
Right.
to your point about not giving up, though, I think there's two simple things to say in addition, which is sometimes you need a break, and that's okay. So like
Right.
you tried doing some therapy, it wasn't a good fit personality wise, or they used modalities that didn't work, or you couldn't explain yourself, or whatever it is, doesn't even matter.
Right.
And you're exhausted or you're a little cynical. That's totally fine. If you need to take a break, take a break. That's okay. And
Sure.
maybe not right now. Maybe you can do other simple practical things to make your life better, like talk to people more or eat better or sleep better or work out better, whatever, right? Simple things might make you feel better in the interim. And maybe that will be enough motivation and drive, like, okay, now I can start doing this other stuff that's actually important to be like there.
Well, sometimes people need to grow up a little bit more to be able to do the kind of work they need to do in psychotherapy and counseling.
Also,
Sometimes.
sometimes people just need to touch the stone more. I think that,
That for sure.
it's
Right.
been my experience, especially in Rehabistan, that, if you really think you got this, then there's not a thing that I can say with all of my degree and intellect and whatever that will magically convince you that you don't got this. It's just,
All right. Right.
and it's and I don't convince people for a living.
You remind me of the experience I had with what I would call a classic narcissistic personality disorder. I ended up treating his son, who, yes, has really needed treatment. But but this guy looked at me after knowing me for one evaluation, which was about an hour and a half, 2 hours, and said, "You can't help me."
Which is right. Which is
Yeah. And probably about 5 or 6 counselors have tried to help him in the past. So he's
Yeah.
partly going on his experience, and partly it was grandiose defense, his arrogance that said, "You can't help me," which is which helped me make a casual diagnosis of him.
Yeah, casual is the correct word. And it's just like, and even if you're 100% correct, he is also 100% correct. Because the other thing I was going to say is, if you don't want help or if you don't want to change, you shouldn't do therapy. It will hurt you.
It will be painful for sure.
Well,
Absolutely.
that's what I mean. It will be bad for you. And we have research to that effect. So if you're not ready, don't do it.
Yeah.
If
I
that's it.
gotcha. I gotcha. Well, let's transition now. We kind of, laid a lot out there for you about psychotherapy.
Yeah.
Now let's talk about intensive outpatient programs, which is more your bailiwick than mine. Although I supervise treatment on young adults and adolescents in an outpatient program for about 25 years, I think. So I do know a lot about them, but you also know a lot about them. Can you describe them for people what they are?
Yeah. Intensive outpatient program, or IOP, is a structured type of clinical intervention. It's, if anyone wants to look this up, there's this thing called the ASAM criteria. ASAM stands for American Society of Addiction Medicine. And every managed care company has to abide by the ASAM criteria in order to use your insurance to pay for treatment, basically.
Well, they're also for mental health too now.
Yes, but you still have to go by ASAM criteria, even if it's mental health, interestingly enough.
Right.
Yeah. So basically all insurance companies have made a deal with ASAM and all this. Anyways, uh, politics. So intensive outpatient is 9 to 15 hours a week of treatment. So 3 hours, 3 days a week, or 3 hours, 5 days a week, basically, is what you'll see. And so the spirit of this is, um, kind of, IOP is either a step up or a step down, depending upon where you're coming from. So if you're just in a rehab somewhere, you might step down to an IOP
Mhm.
so that you can still get a lot of clinical support and structure and psychiatry and groups and counseling and all these things. But you need to go start living life and practicing outside of that super structured rehab environment.
Right.
Or if you've been doing weekly therapy with someone like yourself or whatever, and it's too much. Your suicidal ideation is too much, or your, depression based a motivation. You can't get out of bed, or whatever it is. Like if your symptoms are too severe, if it's
Relapsing and serious relapses.
drug, yeah, or drugs, yeah. Whatever it is, whatever the symptoms are, if it's so severe that it can't be managed once or twice a week in therapy, then you step up to IOP, basically. So it's either step down or step up, depending upon, the circumstances determined by basically the medical team you're working with to figure out how severe your symptoms are. And so IOP is not where you're locked down forever in a rehab. IOP is, again, 9 to 15 hours a week. So 3 hours a day maximum. And so the spirit of IOP is, can we give you a lot of clinical support of whatever kind, group, individual, couples counseling, psychiatry,
Family
Cause-
therapy.
family therapy, case management. It's all the services, all the important types of services.
Right.
But also, you still have the rest of your day to go to meetings, to go to the gym, to go back to school part-time or full-time, to go back to work, to go live at home. So a lot of people in IOP still live at home, for instance, but maybe they work a 9 to 5 job and then they do IOP at night from 5 to 8, for instance. So that's like the working professionals version. But some people who live in IOPs also, or not live in IOPs, some people who are in IOPs also live in a sober living as well. So maybe if you have a severe drug problem, you might need some structured environment to live in while you also go to a semi-structured treatment environment, like an IOP. So those are both very common circumstances. But the goal of IOP,
Yeah, and we will talk more about sober living in a future, podcast. But yes, important.
the goal of IOP is not to dig super deep into those intense things you're talking about earlier. The goal of IOP is to stabilize severe clinical or psychiatric symptoms, basically.
Right on.
So if you could think of IOP like crutches, is the metaphor I would use. Most people, when they break their leg, surgery is very brief. It's a day, it's a couple of days, you're in the hospital recovering or whatever,
How about knee replacement?
Sure. So you'll be in the hospital for a couple of days max, right? And that's rehab. It's very brief.
One day,
Yeah,
maybe.
maybe. Yeah. And then real rehab, like actual like fixing the muscle and repairing it and healing it, happens at lower levels of care in the treatment industry. So IOP is like going to physical therapy and using crutches, essentially. So you'll be in physical therapy for a number of months, maybe even 6 months. And then you'll be on the crutches for a couple of months, probably, maybe even a month if you're lucky. Right. And so that is what IOP is about. IOP is that, like, we've already done the surgery thing. Now we're actually rehabbing, we're actually repairing and strengthening after the surgery has happened. Right. So after you've gone to rehab to get stable from your psychiatric issue or your drug problem, now that you're stable, now we get you into IOP to help you start practicing and fixing and healing and growing, but not in the deepest, profound, my childhood kind of thing. That might show up, but that's not the focus.
And I think you're right on. And I think it's important to note that some IOPs will be more intensive than others.
Sure. Yeah.
You trained in one or worked for one that was extremely intensive. They had people coming to a psychoanalytic doing therapy a number of times a week with the people that were in that treatment program. That's an unusual kind of IOP.
Yeah. It happens. It happens. Some people do depth-oriented therapy in IOPs, and that might be useful because you're going to start the process, but that's not the end of the process.
Well, no, and believe me, intensive work can even be disturbing and not helpful to people
Correct.
that you need to stabilize. So you got to be really careful about that also.
Yeah, and that's the thing is, like, if you get, I always tell I supervise at one IOP right now, and like I always tell my interns that I'm supervising, I know you want to talk about these 3 super deep important things, and this is not the setting for that. So you can help the patient see those things if you want. You can help them understand this is something that we should continue to talk about and work on with long-term therapy. Our job is urgent care. Our job is to fix the immediate problem, stabilize it, start practicing how to manage it better. And then once they're stable enough, then they can start doing some deeper things if they need it, so that they can, if they can actually handle it in some cases, because in some cases people leave IOP and they still can't handle it, to be honest.
And others may very essentially need it. And if they don't get it, they will not stay sober.
Right.
They will not stay unsuicidal. They will not.
Right.
So again, it depends, but I don't want to beat IOPs, into the ground because, I want to get to this last one,
Yeah.
medication, which is a big common thing in the mental health and addictions fields now. More in the addiction fields the last 10, 15 years than ever before, because medicine's been trying to figure out a way to help alcoholics, addicts. And over the last century have been pitifully poor at helping them, so they're trying more and more to help them. So let's get into your discussion of the sledgehammer.
Yes. So a metaphor I often use is what kind of tool is it and what's its job, right? So some tools are blunt instruments like sledgehammers, and some tools are fine instruments like a pen or a scalpel. Yeah. And so it's a really bad idea to use a sledgehammer to take your gallbladder out. That's probably the last. I'm not a physician. I'm not a surgeon. Yes, correct.
Yeah.
I am not a surgeon. So please, feel free to write my licensing board or whatever. It's, I don't believe a sledgehammer is the appropriate tool for the job of removing your gallbladder. I could be wrong though. So the problem is that a lot of people have really strange, in my opinion, reactions to medications, because if you actually understand what the tool is, then you'll see why it might be helpful. Right? So like medications are sledgehammers. They're not scalpels. Zero psychiatric medications are so precise that we know precisely what is happening in the brain when you take them. We have really good ideas. So for instance, every cell in your brain is a neuron, right? That's the word you probably learned in grad school and everyone probably heard or found on the internet.
Sure.
So these neurons have receptors. They're like little sensors that pick up chemicals and attach and all these things. It's 1,000 times more complicated. Come to my psychopharm class and I'll explain to you sometime. But the short version is we know that certain psych meds can increase the number of receptors for serotonin or dopamine or whatever it is, in addition to stabilizing the flow of these neurotransmitters.
Well, like could help anxiety, depression, right?
Precisely.
Yeah.
So creating more availability of these neurotransmitters that are related to mood in some either direct or indirect way, but also changing the architecture of your neurons to some degree, of the receptors for these neurotransmitters, is a thing that's real. We have crystal clear in humans and in animal data that says that actually happens. They're not all placebos. So they do something, but they do very simple things. They're blunt instruments. And so meds are great if you're out of control. That doesn't mean that they are the only solution or the end of the road. It means that for most people that have extremely severe depression or psychosis or a very severe drug problem or severe withdrawals, you'll be put on medications in a good faith way. The doctor is trying to help you stabilize something that is out of control. So
Right.
I think there's a lot of people who hate meds for bad reasons, and there's a lot of people that hate meds for good reasons. However, in my 15 years, I've worked at psych hospitals. I can't imagine trying to do talk therapy with someone who is morbidly psychotic and out of their mind and can't even know who they are in the moment because they're not oriented to reality.
Right.
As smart as I am and as thoughtful and perceptive as I am, I don't have some magical superpower to get that person regrounded in their mind again. And so meds are a necessity for acute psychiatric crises, for all sorts of serious psychological distress that cannot be managed through talk therapy, and especially for severe cravings and withdrawals. I think those 4 reasons are pretty straightforward.
They can help, but even with cravings and not withdrawal. But with cravings though, they can become a way to hang on to something that's similar to the drug they were using. We're talking about narcotics.
We should do an entire episode on MAP. I think that would be good for people.
Yeah, I think so. But so what we're saying is we're not against meds at all.
Yeah, no,
We're for meds for the right reason, right people. But one of the things I like to always mention with meds, like for depression, severe issues that I deal with will defeat meds. They will defeat
absolutely.
the sledgehammer's effect on the brain, and I've seen it over and over again. But there is a place for meds, there's a place for hospitalization, all those kind of sledgehammer kind of things that really help stabilize people, and people need to be stable, and some need help with anxiety, depression until they can get the help that they really need to solve some of those issues that they have that perpetuate depression, perpetuate anxiety, psychosis, Other things is more complicated. We're not going to get into all the bipolar and all those kind of things today because it really does get very complicated. But we want you to know that if you need medicine, go get it.
Yeah.
I recommend
Yep.
psychiatrists, a lot of non-psychiatrists prescribe, and they're well-intentioned, but I would prefer to be a psychiatrist because they have at least more experience and training with matching meds to your neurological system because people are so different neurologically, it's ridiculous. And until we can afford to do PET scans in every brain, which can help you line up meds better, and they cost a fortune to do, unfortunately,
Yeah.
it's going to be talent that knows what med to prescribe for you. And sometimes it's a trial and error too. I like to mention that.
It's always trial and error. It's never not trial and error.
You know, and it's important to be patient with it too, because if you're on a few weeks and it's supposed to start working and it's not working, well, maybe give another week or two, or maybe then you have to go back and try a different medicine.
Or up the dose or change
Or
dose.
the dose, add a different medicine to it now. There's that option also.
Yeah,
And
it's really complicated.
yeah, so we're just saying we want you to get the help you need.
Yeah.
And if you're going through some acute stuff or some chronic stuff that's really worn you down, meds might be an essential part of your treatment program.
Yep.
You know, and we want you to get that help. You know, and that's our word for today. We just introduced you to a couple different kinds of treatment today, and I hope it was helpful to you.
Thanks for listening to Encouragement for Living Life. We hope you were encouraged by today's discussion. If you have a question, you can email us at lockwoodwithlockwood@gmail.com, and we will do our best to answer it on one of our shows. Hope to see you next time.